Good evening, everybody. Tonight's presentation is on hypothalamic-pituitary axis part 2, continuation in the series. Tonight's focus is on neuroendocrine disorders. I'm Dr. Julian Yazigi with DDM Neurosurgery at the University of West Indies, St. Augustine. So let's start by discussing tonight's objectives. We are going to mention the different axes affected in neuroendocrine disorders, explain their pathophysiology and give examples of each. And we'll have a little bit of a focus on SIADH, diabetes insipidus, craniopharyngiomas, and pituitary adenoma towards the end. So let's start. All right. First off, we have the hypothalamic pituitary adrenal axis, the HPA axis, which regulates the stress adaptation, glucose homeostasis, vascular tone, and immune modulation, as well as circadian physiology. So hypothalamic neurons release CRH, which stimulates pituitary corticotrophs to release ACTH. The ACTH then stimulates the adrenal cortex, mainly the zona fasciculata, to produce cortisol, which then feeds back negatively at both the hypothalamus and the pituitary. So a normal secretion is circadian and pulsatile, rising towards the early morning and increasing further during physiological stress. So the normal mechanism is that CRH is produced in the hypothalamic paraventricular nucleus and reaches the anterior pituitary via the portal system. ACTH is derived from POMC and corticotrophs, right? ACTH binds melanocortin 2 receptors in the adrenal cortex, driving steroidogenesis and cortisol release. Cortisol then acts genomically and non-genomically in many tissues, increasing gluconeogenesis, supporting blood pressure, modulating inflammation, and changing protein and fat metabolism. Rising cortisol suppresses further CRH and ACTH release, right? So where do things go wrong? Right, so in primary adrenal insufficiency, the adrenal gland fails. The causes of this include autoimmune Addison's disease, adrenal infection, hemorrhage, infiltration, or bilateral metastatic destruction. Because cortisol falls, the negative feedback brake is removed, so ACTH then rises. In true primary adrenal failure, aldosterone is often also reduced, producing sodium loss, volume depletion, hyperkalemia, and increased renin. The high ACTH comes from increased POMC transcription and can produce hyperpigmentation because POMC-derived peptides include melanocyte-stimulating activity. So the typical pattern, in short, is that it has low cortisol, high ACTH, and often low aldosterone with high renin. In secondary adrenal insufficiency, the problem is the pituitary, right? So ACTH is low, so the adrenals are understimulated and cortisol falls. Because the adrenal zona glomerulosa is mainly regulated by the renin-angiotensin-aldosterone system rather than ACTH, aldosterone is usually relatively preserved. Hyperpigmentation is absent because ACTH is not elevated, and common causes are pituitary macroadenomas, apoplexy, surgery, radiation, or stalk or pituitary compression by masses such as craniopharyngiomas. We'll talk a little bit about this later on, right? Then we have tertiary adrenal insufficiency, which is hypothalamic failure. This reduces CRH, causing reduced ACTH, and then low cortisol. In practice, a classic tertiary mechanism is chronic exogenous glucocorticoid use, which suppresses hypothalamic CRH and pituitary ACTH, thus causing adrenal atrophy over time. Physiology is the same. Upstream suppression leads to downstream hormone deficiency. We also have in here Cushing's syndrome. This was previously discussed, but just to go over it, again, in short, this is a chronic glucocorticoid excess. The mechanism depends on the source, of course, right? In Cushing's disease, a pituitary corticotroph adenoma secretes ACTH autonomously. Cortisol rises, but the tumor only partially obeys feedback, so ACTH remains inappropriately high. In ectopic ACTH syndrome, a non-pituitary tumor, such as small cell lung cancer, produces ACTH independent of the hypothalamic pituitary control, so feedback is effectively just bypassed at that point. In an adrenal cortisol-producing adenoma or carcinoma, cortisol is high and ACTH is suppressed by feedback. So what does this really mean? So the clinical consequences of this is that low cortisol will cause fatigue, anorexia, weight loss, hypotension, and poor stress tolerance, whereas high cortisol would cause insulin resistance, muscle wasting, skin fragility, central adiposity, hypertension, and immune dysfunction. The key here is that ACTH level helps to localize um, the lesion, more or less, when the HPA axis is compromised. Moving onwards to the hypothalamic-pituitary thyroid axis, the HPT axis, this regulates basal metabolic rate, thermogenesis, and cardiovascular tone. In addition to that, it's responsible for lipid metabolism, gut motility, and critical aspects of brain development and CNS function. Hypothalamic TRH stimulates pituitary thyrotrophs to secrete TSH, which then stimulates thyroid follicular cells to synthesize and release T3 and T4. T3 is the main active hormone at tissue level, and thyroid hormones suppress both TRH and TSH by a negative feedback mechanism. So normally, TSH binds to the TSH receptor on thyroid follicular cells, increasing iodide uptake, thyroglobulin iodination, and thyroid hormone synthesis and gland growth. And most hormones released is T4, which is converted peripherally to T3. T3 acts through nuclear receptors to regulate transcriptions of genes involved in metabolism and mitochondrial activity, as well as sympathetic responsiveness and neural development. Where this goes wrong in primary hypothyroidism, for example, is that the thyroid gland itself fails, right? So T4 and T3 fall. This removes negative feedback, so the pituitary increases TSH, thus causing diseases such as Hashimoto's, thyroiditis, iodine deficiency, thyroidectomy, and so on. Since the gland cannot respond normally, TSH rises in an attempt to drive even more hormone production, right? So in this case, we would see a low free T4 and a high TSH. Whereas with central hypothyroidism, here the problem lies in the pituitary or the hypothalamus in and of itself. TSH secretion is reduced or biologically inappropriate, so the thyroid receives inadequate stimulation and free T4 falls. The key point is that TSH is not a reliable sole marker in central hypothyroidism. It may be low, normal, or only mildly abnormal despite a low free T4. Causes of this include pituitary adenomas, history of prior pituitary surgery, cranial irradiation, infiltrative disease, and hypothalamic pituitary or pituitary tumors, right? For example, like a pituitary macroadenoma. The pattern typical of this, in contrast to the previous, is that this one has low free T4 with low or inappropriately normal TSH. Then we have primary hyperthyroidism. The thyroid is overactive, independent of the pituitary drive in this case. Like in Graves' disease, TSH receptors antibodies stimulate the receptor, mimicking TSH. The gland then produces excess T4 and T3, which suppresses pituitary TSH. In toxic multinodular goiter or toxic adenoma, autonomous thyroid tissue produces the hormone without really needing TSH to be produced. Right? So the pattern here is that you have a high free T4 or T3, but albeit a suppressed TSH. Then we have secondary hypothyroidism, which is rare. And so in this case, a TSH secreting pituitary adenoma causes elevated or inappropriately non-suppressed TSH despite high thyroid hormone levels. Here, the pituitary tumor itself actually ignores the normal feedback. Clinical consequences of this in low thyroid hormone is slow metabolism, fatigue, weight gain, cold intolerance, constipation, and bradycardia. Whereas in excess, it increases adrenergic tone and metabolism, causing weight loss, tachycardia, heat intolerance, tremors, and anxiety. In central disease, the crucial mechanism point is that free T4 reflects tissue hormone status better than TSH alone, right? Onwards to the growth hormone IGF-1 axis. The GH axis regulates linear growth in childhood in protein and fat, carbohydrate, and body metabolism and body composition in adulthood. Hypothalamic GHRH stimulates somatotropes while somatostatin inhibits them. Very important. right? The pituitary releases growth hormone in pulses, especially during sleep. Growth hormone then stimulates hepatic and peripheral production of IGF-1, which mediates many growth promoting actions and feeds back to suppress GH output. In its normal mechanism, GH is secreted in a pulsatile manner, so random that GH values are difficult to interpret, right? GHRH promotes somatotroph synthesis and the release of GH, while somatostatin would restrain it, as we've mentioned. But GH acts directly to promote lipolysis and antagonizes insulin action, and indirectly through IGF-1 to stimulate chondrocyte activity, bone growth, and anabolic processes. IGF-1 suppresses GHRH and GH secretion and also promotes somatostatin tone. Why is this important? Because when things go wrong, what happens is that, we get a GH deficiency, and this can maybe hypothalamic, pituitary, congenital, or acquired. And in children, it causes poor growth, velocity, and short stature, while in adult, it causes increased fat mass, reduced lean mass, dyslipidemia, lower exercise tolerance, and reduced quality of life. Pituitary tumors like craniopharyngiomas, surgery, radiation, and trauma, as well as infiltrative disease, are common acquired causes of this. In the event that there is excess, it's usually of GH, growth hormone. It's usually due to a pituitary somatotroph adenoma. The tumor secretes GH autonomously, causing increased IGF-1. In children before epiphyseal closure, this causes gigantism, whereas in adults, it may cause acromegaly with soft tissue overgrowth, enlarged hands and jaw, insulin resistance, cardiomyopathy, and sleep apnea. Because secretion is autonomous, feedback from IGF-1 is ineffective at the tumor level, right? So why does this look so unusual? Well, unlike cortisol or thyroid hormone, GH is episodic. And so the physiology is best captured by IGF-1 and by stimulation suppression testing, not rather than one random GH level. And this feature is directly tied to the pulsatile neuroendocrine control of this axis. With regards to the hypothalamic-pituitary gonadal axis, the HPG axis, this governs sexual development, fertility, menstrual cycling, spermatogenesis, libido, and bone health. Hypothalamic neurons release GnRH impulses, which stimulate pituitary gonadotrophs to release luteinizing hormone and follicle-stimulating hormone, or FSH. These act on the gonads to produce testosterone, estradiol, progesterone, and gametes. Sex steroids feed back negatively on both the hypothalamus as well as the pituitary. In its normal mechanism, pulsatility is the key. Intermittent GnRH drives gonadotroph responsiveness, whereas continuous GnRH exposure suppresses it. In males, luteinizing hormone stimulates Leydig cells to make testosterone, and FSH supports Sertoli cell function and spermatogenesis. In females, LH and FSH coordinate follicular maturation, ovulation, and cyclic estrogen progesterone production. These sex steroids support reproductive tissues as well as secondary sexual characteristics in puberty and adulthood, and as well as assist in muscle and bone tone, right? But they also help to modulate brain function. At the pathophysiology level, in primary hypogonadism, the gonads fail. So then sex steroids production falls. Feedback is lost and LH, FSH rises, right? Causes of this include things like Turner syndrome, Klinefelter syndrome, gonadal injury, orchitis, or ovarian failure, but can also include mechanisms from chemotherapy treatments as well as autoimmune gonadal diseases. Whereas in secondary hypogonadism, the pituitary itself fails to release enough LH or FSH, so the gonads are then understimulated and sex steroids fall. The causes for this include pituitary adenomas, hyperprolactinemia, as well as surgery, radiation, or infiltrative pituitary disease. We also have tertiary hypogonadism, which warrants a mention. The hypothalamus in this case does not produce adequate GnRH pulsatility, and causes of this include congenital GnRH deficiencies such as Kallman syndrome, functional hypothalamic amenorrhea due to undernutrition or stress, and hypothalamic tumors. Pubertal disorders can arise from this, such as central precocious puberty, which occurs when GnRH pulsatility starts too early, activating the entire axis prematurely. But we can also have the opposite, where we have a delayed puberty, which may reflect failure of the hypothalamic GnRH activation, pituitary gonadotropin deficiency, or even primary gonadal failure, as we would have discussed before. Consequences of this, clinically speaking, is that when sex steroids are low, consequences arise, such as amenorrhea, infertility, delayed puberty, as well as erectile dysfunction, reduced libido, and reduced muscle mass. In addition to that, low bone density tends to accompany it as well. The localization rule again matters. So high gonadotropins imply gonadal failure, whereas low or inappropriate gonadotropins imply a more central etiology, right, or central disease. The prolactin axis is next. So in the prolactin system, it's a little unusual, and this is because it's controlled mainly by tonic inhibition as opposed to tonic stimulation. Hypothalamic dopamine suppresses lactotroph prolactin secretion. When dopamine delivery falls, prolactin then rises, right? So TRH can stimulate prolactin somewhat, but dopamine is the dominant regulator in this case. And in normal situations, dopamine from the hypothalamus would travel down the pituitary stalk via the portal circulation and restrain lactotrophs. During pregnancy and lactation, this inhibition is reduced and prolactin secretion increases to support mammary gland development and milk production. Prolactin also suppresses GnRH, which is why hyperprolactinemia commonly causes hypogonadism as well as infertility. The pathophysiology includes that of a prolactinoma, a lactotroph adenoma, which secretes prolactin autonomously, right? In this, hyperprolactin suppresses GnRH and reduces luteinizing hormone and FSH, and therefore lowering testosterone or estrogen, depending on the biological sex. The result is amenorrhea, galactorrhea, infertility, decreased libido, and erectile dysfunction. Large tumors may also cause headache or bitemporal visual field loss. Aside from prolactinomas, we have the stalk effect. So any mass compressing the pituitary stalk will reduce hypothalamic dopamine delivery. And so without dopamine inhibition, prolactin will then rise. With this this includes non-functional pituitary adenomas as well as craniopharyngiomas. The mechanism is not a prolactin secreting tumor, rather it is disinhibition. Other causes could be due to, for example, drug-induced hyperprolactinemia, where dopamine antagonists such as antipsychotics block dopaminergic restraints on lactotroph, so prolactin increases. And again, the mechanism is the removal of inhibition. Why is this important? So it's the classic example of a pituitary hormone that increases when the stalk is interrupted. Most other pituitary hormones fall with stalk damage because they lose hypothalamic stimulation. But with the prolactin axis, prolactin actually rises because it loses hypothalamic inhibition, right? Now, we have the posterior pituitary and arginine vasopressin axis. So this is not a classic trophic gland axis like the thyroid or the adrenal control, or like adrenal control. It's mainly a water balance regulatory system, right? So arginine vasopressin, also called ADH, is synthesized in the hypothalamus and transported to the posterior pituitary for storage and then release. The major stimulus is increased plasma osmolality, with volume depletion as an additional strong trigger. AVP acts on renal collecting ducts via V2 receptors to increase aquaporin insertion and water reabsorption. Normally, when plasma osmolality rises, the hypothalamic osmoreceptors will trigger thirst and AVP release. AVP will then bind to V2 receptors in the collecting ducts, raising cyclic AMP, and this causes aquaporin 2 channels to insert into the apical membrane. More water is reabsorbed, urine becomes more concentrated, and plasma osmolality falls back towards normal. With low osmolality, AVP is suppressed, and then dilute urine is produced. So, how can this go wrong? Well, in central AVP deficiency, the pathophysiology states that central AVP deficiency is essentially another name for diabetes insipidus, right? So this occurs when hypothalamic production or posterior pituitary release of AVP is impaired. And causes of this could include a history of neurosurgery, pituitary stalk injury, craniopharyngiomas, trauma, infiltrative disease, as well as idiopathic autoimmune injury. Without AVP, the kidney cannot appropriately concentrate urine, so large volumes of hypotonic urine are passed. If thirst is intact, the patient drinks enough water to compensate. However, if thirst is impaired, severe hypernatremia can follow. Right? We have nephrogenic AVP resistance as well. In this one, the hormone is present, but the kidney does not respond. Right? Causes of this include a history of lithium use, hypercalcemia, hypokalemia, chronic kidney disease, or inherited receptor channel defects. Right? The pathophysiology is failure of the collecting duct to respond to AVP signaling or a disrupted medullary concentration gradient. In here, we also discuss SIADH, wherein AVP is excessively relative to plasma osmolality, right? And water is retained, diluting serum sodium and therefore lowering the osmolality. Causes of this are usually CNS disease, pulmonary disease, drugs, and ectopic production. The key mechanism here is water retention out of proportion to sodium, giving a euvolemic hyponatremia in many cases. We'll discuss this as well as diabetes insipidus a little bit later down in this presentation. So let's talk about craniopharyngiomas. We mentioned it multiple times in a couple of the other axes as a cause of some of the disorders. So craniopharyngiomas are benign WHO grade 1 epithelial tumors arising from embryological remnants of Rathke's pouch along the cellar-supracellular axis. Despite being histologically benign, they're clinically aggressive due to their intimate relationship with the hypothalamus, optic apparatus, the pituitary gland, and the third ventricle floor. There are two distinct molecular and pathological subtypes. So we have the adamantinomatous subtype, which is more common in children and is associated with a CTNNB1 mutation and activation of the WNT signaling pathway. It's typically cystic, calcified, and locally infiltrative with cysts containing cholesterol-rich fluid. Importantly, this subtype incites a strong inflammatory response, which contributes to adherence to surrounding neurovascular and hypothalamic structures. The papillary subtype, on the other hand, is seen predominantly in adults and is associated with a BRAF V600E mutation and tends to be more solid, less calcified, and more surgically plane defined, which has implications for resectability as well as for targeted therapy. From an anatomical perspective, the tumor's position is critical, right? So it lies at the convergence of the hypothalamus superiorly, the pituitary stalk and gland inferiorly, and the optic chiasm anteriorly, often extending into the third ventricle. This explains the classical clinical triad, I should say, of visual disturbance, endocrine dysfunction, and features of raised intracranial pressure. Visual symptoms arise from the compression of the optic chiasm, classically producing bitemporal hemianopia, although variations occur depending on the tumor position. Raised intracranial pressure may occur due to obstruction of CSF pathways or due to the mass effect exerted by the tumor. The most important aspect, however, is the neuroendocrine and hypothalamic dysfunction. So early in the disease, pituitary stalk compression leads to the disruption of hypothalamic releasing hormones and dopamine transport. This produces the so-called stalk effect, characterized by mild to moderate hyperprolactinemia due to loss of dopaminergic inhibition, as we would have mentioned, but as well as progressive deficiency in growth hormones, gonadotropins, TSH, and ACTH. As the tumor enlarges, or even with surgical manipulation, Direct damage to the hypothalamus results in hypothalamic syndrome. This includes hyperphagia and hypothalamic obesity due to disruptions of satiety centers, reduced sympathetic tone, and altered leptin signaling. Additionally, there are disturbances in circadian rhythm, sleep regulation, thermal regulation, and behavior, reflecting involvement of multiple hypothalamic nuclei. Posterior pituitary involvement usually leads to arginine vasopressin deficiency, resulting in diabetes insipidus. This may present preoperatively or even develop postoperatively, particularly if the stalk is transected or the posterior pituitary is damaged. Radiologically, the MRI typically demonstrates a mixed cystic and solid lesion in the suprasellar region, often with calcifications in the adamantinomatous subtype, which is better visualized on CT. The relationship to the hypothalamus is particularly important for surgical planning and prognostication, and management is centered on balancing tumor control with preservation of hypothalamic function. While gross total resection offers potential cure, it does carry a high risk of hypothalamic injury in tumors with hypothalamic involvement. Therefore, a more conservative approach, like subtotal resection followed by radiotherapy, is often favored in such cases. For papillary tumors, targeted therapy with BRAF and MEK inhibitors represents a significant advancement. Postoperatively, endocrine complications are common and often permanent. Patients frequently require lifelong hormone therapy, including glucocorticoids, thyroid hormone, sex steroids, growth hormone, and desmopressin. Long-term morbidity is dominated by hypothalamic dysfunction, particularly obesity and metabolic syndrome, rather than tumor recurrence alone. In short, craniopharyngiomas should be conceptualized not merely as a tumor, but as a chronic neuroendocrine disorder where the principal challenge lies in preserving hypothalamic and pituitary function while trying to achieve durable tumor control. Pituitary adenomas are also benign neoplasms. These, however, arise from the adenohypophysis and represent the most common tumors of the sellar region. They account for approximately 10 to 15% of all intracranial tumors and are typically slow growing but clinically significant due to both hormone secretion and mass effect on the surrounding structures. They're broadly classified based on size and function. By size, microadenomas are less than 10 millimeters, while macroadenomas are greater than 10 millimeters, and are more likely to produce compressive symptoms. By function, they are divided into functioning adenomas, which secrete hormones, and non-functioning adenomas, which either do not secrete active hormones or secrete biologically inactive forms of those hormones. From a cellular perspective, pituitary adenomas arise from monoclonal expansion of differentiated pituitary cell types, including lactotrophs, but as well as somatotrophs, corticotrophs, thyriotrophs, and gonadotrophs. Their behavior is influenced by transcription factors like PIT1, SF1, and TPIT or TPIT, which determine lineage differentiation. Clinically, the presentation depends on whether the tumor is functioning or non-functioning. In functioning adenomas, patients present with syndromes of hormone excess. The most common is prolactinoma, where excess prolactin suppresses GnRH, leading to hypogonadism, infertility, and galactorrhea. Growth hormone secreting adenomas cause acromegaly in adults, characterized by soft tissue overgrowth, as well as insulin resistance and cardiovascular complications. ACTH secreting adenomas cause Cushing's disease, resulting in hypocortisolism with metabolic, cardiovascular, and immunological consequences. TSH secreting adenomas are rare, but can present with hyperthyroidism. By contrast, non-functioning adenomas, which are often gonadotroph derived, typically present later due to mass effect. Right, as they enlarge, they compress the optic chiasm, leading to bitemporal hemianopia, and may even invade the cavernous sinus, which thereby affecting cranial nerves 3, 4, and 6. Compression of the normal pituitary leads to hypopituitarism, most commonly affecting growth hormone and gonadotropins first, followed by TSH and ACTH. A key concept is the stalk effect here. Compression of the pituitary stalk disrupts dopaminergic inhibition from the hypothalamus, resulting in mild to moderate hyperprolactinemia, even in non-functioning tumors. Posterior pituitary involvement is less common due to its distinct blood supply, but large tumors or surgical intervention may thereby result in diabetes insipidus through that mechanism. Radiologically, MRI with contrast is the imaging modality of choice. Adenomas typically appear as hypo or iso-intense lesions on T1 weighted imaging with variable enhancement. Macroadenomas may show suprasellar extension and chiasmal compression. Cavernous sinus invasion is assessed using criteria such as NOSP grading. Managements depend on the tumor type, of course, with prolactinomas being primarily treated medically with dopamine agonists such as cabergoline, which reduces prolactin levels and tumor size. Other functioning adenomas are typically managed surgically, most commonly via a transsphenoidal approach. Endoscopic transsphenoidal surgery is now standard due to its improved visualization and reduced morbidity. Radiotherapy is typically reserved for residual or recurrent disease or when surgery is contraindicated. Medical therapy may also be used adjunctively such as somatostatin analogs for acromegaly or steroidogenesis inhibitors for Cushing's disease. Postoperative complications typically include cerebrospinal fluid leaks, hypopituitarism, disorders of water balance such as diabetes insipidus or SIADH, often occurring as part of the triphasic response. Long-term follow-up is very essential in these cases as patients may develop delayed endocrine deficiencies or even tumor recurrence. Hormonal replacement therapy is tailored based on the deficits with priority given to glucocorticoid replacement in ACTH deficiency. In short, these pituitary adenomas are common benign tumors of the sellar region that present either through hormone hypersecretion or mass effect, and their management requires a multidisciplinary approach, balance in endocrine control, as well as surgical resection when possible. As far as diabetes insipidus, or more precisely arginine vasopressin deficiency, when central in origin, it's a disorder of water balance characterized by the inability of the kidney to concentrate urine, resulting in polyuria and polydipsia. Under normal physiology, arginine vasopressin is synthesized in the supraoptic and paraventricular nuclei of the hypothalamus and transported along axons to the posterior pituitary, where it's stored and released. Its secretion is primarily regulated by plasma osmolality via hypothalamic osmoreceptors, with volume status serving as a secondary stimulus. Once released, AVP acts on V2 receptors in the renal collecting ducts, activating adenylate cyclase and increasing cyclical AMP, which leads to the insertion of aquaporin 2 channels into the luminal membrane. And this facilitates water reabsorption, allowing the kidneys to concentrate urine and maintain plasma osmolality. In central diabetes insipidus, there is a deficiency of AVP due to the disruption of the hypothalamic neurohypophyseal system. This may occur due to tumors such as craniopharyngiomas, which we've discussed, but also because of the causes previously mentioned, like pituitary surgery or traumatic brain injury, or any form of infiltrative disease. This absence of AVP leads to failure of water reabsorption, resulting in the excretion of large volumes of dilute urine. Clinically speaking, patients present with polyuria, often exceeding 3 liters per day, as well as nocturia and compensatory polydipsia. If the thirst mechanism is intact, as we mentioned before, plasma sodium may remain relatively normal. However, in case of hypothalamic damage where thirst is impaired, referred to as adipsic diabetes insipidus, right? Patients are unable to compensate, leading to even more severe cases of hypernatremia and dehydration. Laboratory findings will typically show low urine osmolality and specific gravity as well, with relatively high serum osmolality. The water deprivation test helps confirm the diagnosis, and administration of desmopressin distinguishes central from nephrogenic diabetes insipidus, with central forms showing a marked increase in urine concentration. In our neurosurgical practice, diabetes insipidus is a common postoperative complication, particularly after pituitary or suprasellar surgery. It could be transient at times, but permanent, and is usually often part of the triphasic response seen after pituitary stalk injury. Management of this includes replacement with desmopressin, as well as careful monitoring of fluid balance and regular assessment of serum sodium. Over replacement must be avoided, as it can lead to water retention and hyponatremia. In short, diabetes insipidus is a disorder of impaired water conservation due to AVP deficiency or resistance, with central forms being particularly relevant in lesions affecting the hypothalamic-pituitary region. Here we have a nice little illustration, just so a mental image can be had of the difference between SIADH and diabetes insipidus on clinical presentation, right? So SIADH, or syndrome of inappropriate antidiuretic hormone secretion, is a disorder characterized by excessive release of arginine vasopressin relative to the plasma osmolality. This results in impaired free water excretion and dilutional hyponatremia. Physiologically, AVP is secreted in response to an increased plasma osmolality or decreased effective circulating volume. So in SIADH, this regulation is disrupted and AVP is released despite normal or low plasma osmolality. The excess AVP acts on collecting ducts of the kidney via V2 receptors, promoting water absorption, which leads to expansion of the total body water. But because sodium content remains unchanged, the result is dilutional hyponatremia. Importantly, the body responds to this mild volume expansion by increasing natriuresis, leading to a euvolemic state clinically, despite biochemical dilution. Common causes of SIADH include central nervous system disorders such as subarachnoid hemorrhage, traumatic brain injury, tumors, and infections. It may also occur due to ectopic AVP production, most notably in small cell lung carcinomas, or as a side effect of medications including SSRIs, carbamazepine, and cyclophosphamide. Clinically, symptoms are related to the degree and rate of fall in serum sodium, with mild hyponatremia resulting often in headaches and nausea, while severe or rapid drops can lead to cerebral edema, which could result in confusion, seizures, and even a coma. Laboratory findings in this case include hyponatremia, low plasma osmolality, inappropriately elevated urine osmolality, and elevated urine sodium in the absence of hypovolemia or edema-forming states. These features distinguish SIADH from other causes of hyponatremia. Management depends on the severity, and fluid restriction is the mainstay in mild cases. However, in severe or symptomatic hyponatremia, hypertonic saline may be required, but correction must be carefully controlled to avoid osmotic demyelination syndrome. Vasopressin receptor antagonists could also be used in select cases. In our neurosurgical patients, SIADH is particularly relevant in the postoperative period, often occurring several days after surgery as part of the triphasic response following pituitary stalk injury. In short, both SIADH and diabetes insipidus can occur as post-op complications, where SIADH represents the pathological opposite of diabetes insipidus, with excessive AVP leading to water retention and dilutional hyponatremia, and is a critical consideration in the management of patients with central nervous system disease. That concludes my talk for today. Thank you, everybody, and these are my references.